the role of nutrition in diabetes management, and I think our presenter is also going to talk about alternatives when it comes to nutrition management in diabetes. So we have a presenter, clinical dietitian. She's called Betty Okere. I think the name is familiar to most of us. And the session will be moderated by her colleague, who's called Tracy Ann Jerry-Washeke, who's also a registered and licensed dietitian nutritionist. So I'll welcome the moderator to just welcome the presenter. Thank you.
Good afternoon, everyone. Good afternoon, everyone. Perfect. So this session is about to be very interesting because I know the person who's going to present is a guru in this. She's an icon if you're in diabetes and you deal with patients, nutrition. The one person that I run to is Betty Okere. So this session, she's not only a devoted nutritionist, she's a mentor. She mentors so many of us, and she believes in evidence-based. So this session, we're just gonna deal mostly about evidence-based, and most of the questions that even our patients, our clients ask us basically about nutrition, some answers we'll find. So without further ado, please help me welcome Betty Okere.
Thank you very much. And just as we have had, the big question is whether we should eat or not. To eat or not to eat. Alternative therapies in nutrition. What comes to your mind when you hear that topic? What comes to your mind when you hear that topic? What do you think I'm going to talk about? That today you stop eating? Somebody says supplements. What do you think I'm going to talk about? Healthy eating. What about healthy eating? I'm going to tell you guys not to eat today. You'll probably be taking what after all this? And I have no conflict of interest that I need to declare. We are all moving towards a healthier lifestyle. All of us are trying to ensure that we incorporate something that is healthy, especially with regards to food. There is so much that is being brought into the market in terms of if you use this, you'll probably have a longer life, you'll have less fatigue, you will be able to sleep better, you will have better mental health and all that. But what is the truth? How much do we know about what is brought to us? One of the things that we talk about when that happens is something called alternative therapies. But what is alternative therapy? When I talk about alternative therapy, do you think about herbal medicine? Have your patients come to you and told you they are taking something and they have stopped taking the medication that you gave them because the other something that they're using seems to be working much better? Do you believe them? Do these things work? Okay, you don't believe them, but they swear by it. They were not sleeping. You had started them on some medications to help with their insomnia. They have stopped your insomnia medications. They are taking the alternative therapy and they are sleeping. They actually have a record of better sleep. So do you believe them or not? So what is alternative therapy? And especially with regards to nutrition. Now, the definition is that when we are talking about alternative therapy, we are using something instead of the conventional medication or conventional nutrition as we know it. Therefore, it is coming to take over the place of conventional medication. That is why we call it alternative therapy. Also, most of these alternative therapies, especially nutrition will put a caveat on offering healing effects. That which your doctors don't tell you. That which the pharmaceutical industry is hiding from you. That which is supposed to make you be better when you're not using the medication. So it gives us, it puts out effects of having a healing, probably not even a cure. Usually we have very limited or no scientific evidence or backing for most of the alternative therapies that exist. And when we have, either these have been done on animal, so they're animal studies, not necessarily human studies, and if they're human studies, the numbers are very few, and so we might not be able to replicate it to a much bigger population. And we do not have, per se, up to now, any formal medical institution or medical facility that teaches on alternative therapy. We do not have anything formal. So we will not have a curriculum that says, today we'll be learning about this particular food, and it is because it is supposed to be used instead of metformin or something like that. We don't have that. Now, what is the opposite of, or what is the other subset of alternative therapy or alternative nutrition therapy? There is complementary therapy. And as the English word would suggest, complementary therapy, meaning that it is able to be used alongside what we already know as conventional therapy or conventional treatment. So we are not necessarily removing that which you know. You are continuing to use your medications, and as long as there is no contraindication to it, you can still be able to use it. So we use it alongside other therapies, conventional therapies. Again, not so much scientific evidence backing, and it is based on the belief that if we have a combination of what we're doing together with medication, it makes it better, all right? Our grandmothers were very good at that. Yes, you're taking your medication, but also if you drink this particular flour, you're going to be healed. Some of us were so scared of saying we had stomach aches, because then we'd be giving some very, very, very bitter leaf or flour, and you just have to be healed, because if you say you're not healed, you'll be given again. It was so bitter and uncomfortable. So what is the question? Is there really alternative therapy, or there is really just medicine that works and that which doesn't work? There's just nutrition that works and that which doesn't work, all right? We will be able to discuss that. I start. There is a lot that we can talk about in nutrition in terms of alternative therapies. But then the question is, what is more common? What is coming to our practice every now and then that the patients are asking about? Turmeric is the first one. How many of us in this room have been asked about the healing properties of turmeric? Yes, and what were you told it does? Anti-inflammatory. What else? Antibacterial. And so many other things, including probably it should even be able to cure all your stomach upsets. So yes, it is a nutraceutical, it's a natural, it has the bioactive polyphenol molecules, and the three molecules, the compounds that you're talking about is the curcumin, demethoxycurcumin, and this curcumin, all right? And then there are claims that it can cure cancer. It is an antioxidant. It is an anti-diabetic. So I know people who make the turmeric tea and swear by it, that after they take it, then their blood sugars are low. They even induce hypoglycemia and all that. Again, I am calling them claims because nobody has really been able to substantiate some of these things, all right? And from research, what were we able to find? Yes, it has got some strong anti-inflammatory properties, antioxidative, and has a bit of substantial anti-carcinogenic, anti-mutagenic, and neuroprotective properties, as well as antibacterial. There is evidence. Again, remember, this has been done on what? It has been done on animal studies. So we are yet to replicate most of this in human beings to see if that works. And then we also have some systematic reviews on the same, which shows that this is actually true, but may need to be studied further. So there is the curcumin itself, that component, has been seen to reduce oxidative stress, preservation of mitochondrial function, and I think we had about that in the afternoon, neuroinflammation reduction, insulin sensitivity improvement, and again, that is from what patients would say. I took turmeric, my sugars were low, yet I took the same amount of carbohydrates that I had in the previous meal when I didn't take the turmeric, and my sugars were high. All right? So a few papers that I was able to come across. One was that on the effect of turmeric and ginger supplementation on immunity. And it actually showed that there was a bit of improved immunity. Then the molecular mechanisms of inhibition of cell proliferation using the active compounds in the curcuma longa, which is basically the turmeric. And then the question is it when it is used as powder, or is it when it is used as the natural ginger root that it works more effectively? Then what are the effects of curcumin on human health? This was interesting because there is a promise on anti-cancer activity, but they said that that compound needs to be tested further. So yes, it shows there might be some protection to the cells, but it must be studied further. All right, what is the downside to turmeric use? So there is poor pharmacological characteristics, like limited solubility. It is also very unstable. And the metabolic conversion so that we are able to apply it medically is also very limited. So yes, it may have all this, but in what form do you need to consume it? For how long will it last in your body? What amounts will give you the effect that you require is still in discussion. And then depending on the route of admission, again, that may add on to the challenge. And lastly, it reduces drug efficacy, especially in cancer treatment. So yes, somebody is using it because it's an anti-inflammatory. They have said it has some anti-cancer properties, but then it might reduce the effect on drug efficacy. And then it also increases stomach acids. That's supposed to be acids, and therefore it interferes with the use of antacids. So if you have your patient who is complaining of, they have gastritis, they have stomach issues, and then they have the antacids being administered, and they are consistently taking this turmeric, that might not work for them. And then the problem exacerbates. And if they are on blood thinners as well, that might be an issue because they might bleed out if they have a cut. So again, those are things that we need to take care of. And all these studies did not even tell us how much is too much. The next one is cinnamon. What have you heard about cinnamon? Tastes better with sugar? Or tastes better than sugar? Sometimes, yes? Has a role in reducing blood glucose? True or, yes? Yes, it has some studies, and especially in colon cancer and all that stuff. We'll look at that and see. So again, it is a spice, and it's from the bark of the trees. So when you have it before it's powdered, you actually see it's like a dried bark. Does it improve on taste? Yes, it does. So sometimes if you have a patient who, because they have unregulated blood glucose and you've told them to reduce on their sugar intake, but they still have that, they still want to taste some sugar, if they added it to their food, it would still taste nice and has that nice aroma. There are some 35 clinical trials that we're able to just have a look at in passing, and these ones at least gave us a dose of 1.5 grams per day, and that had got an effect on cholesterol reduction, except triglycerides. And then when used as an antioxidant in polycystic ovarian syndrome study, it led to improved lipid profile. But in this particular study, they actually used it as a capsule. So they made it better, used it as a capsule, and it was administered for 12 weeks, and there were some improvements. So again, that's another study, the beneficial effects of cinnamon among patients with metabolic diseases. It's a systematic review, but it's looking at what other people have done and what they have said. Also in type 2 diabetes, this was a randomized controlled trial, and the reason why I put it there, it is because the patients who received it were able to have improvements in their anthropometric measurements, so the BMI, as compared to those who had placebo. It also had some effects, positive effects on reduction of cholesterol. Again, that is the ones who use 1.5 grams a day, but what if you used less or you used more? For how long? Yes, that was the 12 weeks, but do we have something that followed up after those 12 weeks to see if that was a sustained benefit? But in terms of anthropometry, that was really loaded. Did we find anything negative in terms of the challenges? Yes. If we are talking about use of cinnamon in pregnancy, again, depending on amounts which have not been stated in most studies, it can lead to uterine contractions, which can cause a miscarriage or premature labor. So it's not very safe in use in pregnancy. Cinnamon inhalation can also trigger a hypersensitive airway and irritate the mucosal membrane, and therefore having the upper respiratory problems. And in theory, and that is what most papers state, it may increase anticoagulation. Okay? Okra water. So is okra a fruit or a vegetable? It's a vegetable. Why? Because we cook it. It's not a fruit. What's the definition of a fruit? Must have a seed. But doesn't okra have a seed? So is it a fruit or a vegetable? It's a fruit. So you can have it in a fruit salad. All right. It's a vegetable, but also because it has the seeds, then some people still consider it a fruit, but I wouldn't find it in my fruit salad. No. It lessens, the claim is that it lessens diabetes symptoms and promotes insulin sensitivity. Now this also from practice, I have had it from, especially the Somali patients, they'll tell you, the days that I have my okra with my normal food, the normal amounts that you've prescribed, my sugars tend to be low. If we did further studies, we'd be able to ascertain this. And one of the studies that was there was a randomized control trial. It was a double-blinded, 120 patients. Again, the numbers are still very low, but it simply tells us. And the experiment was for 6 to 8 weeks. They were receiving it as a capsule, I think because it's easier. And from the both groups, there was a reduction, significant reduction in fasting blood sugar, random blood sugar, and of course the A1C. However, it was to be used as adjunct treatment together with what else we are using or we are advising the patients to use when they have diabetes. So is the okra water better or is it the okra itself? Okay? So again, that is a systematic analysis with 331, 8 studies with 331 patients with type 2 diabetes, and that when they used the okra treatment, they had the A1C reduced, but it was not so significant between the group that had the placebo and the one that had the okra capsules used. So the conclusion, yes, it can be used as a supplemental dietary nutrient, especially for prediabetes and type 2 diabetes to regulate. It has the potential to regulate blood sugar, but cannot be used to replace diabetes medication, all right? So what challenges? It is high in potassium, and just as we've heard from the nephrologist, we cannot therefore use it in patients with CKD or DKD because it would be contraindicated. Then we'd say, what about leaching? We can leach it, but how can you leach okra? Anyone who's seen okra, when you put it in water, it's actually slimy and you probably will not get anything out of it. So leaching becomes a problem. And we are probably better off using it as a vegetable cooked and with all the fiber whole instead of using it as water. One of the speakers in the afternoon talked about mwarubaini and the one which heals a lot of diseases, but moringa is the other one. Yeah? You've heard about what it can do. It probably can bring somebody back to life, right? Yes. So, and it is being sold so expensively and everywhere else. So moringa oleifera, a medicinal plant, and it, again, just like the others, anti-inflammatory, antioxidative, which results into glucose modulation, lipid metabolism, and preservation of target organ damage. So again, they are putting it as something that would protect probably the kidney if you have severe hyperglycemia. But what is the content of the protein in moringa, for example? And there are promises of improved fertility and all that. So there's this comprehensive review and the pharmacological activities. And if it actually leads to toxicity and even poisoning in some people, and as we move on, we'll be able to see that. And then what is the use of moringa in cardiometabolic disorders? Again, this only just showed a bit of improvement in lipid outcomes, but not very evident. So substantial evidence of positive contribution is still lacking, and we need more studies on it. In terms of improving the protein content, yes, that has been loaded by very many studies. So what are the challenges? We know moringa is moringa, and sometimes it's just powdered. And unless you're buying it from a reputable place, anybody can powder anything. But the truth is, you cannot use the trunks and the branches because that would cause you abdominal pain and even poisoning. Unfortunately, if you're talking to a patient who had another disease and they succumbed to it, what they would think is the fact that the medication you gave them is what made them succumb, and not necessarily that they introduced a foreign substance that they did not know its use. And if you must use this, then it must be guided by a competent person with the relevant information. I don't think I'm one of them. I would not guide you on the use of moringa because I do not know how much is too much. And the studies are very, one says a gram, another one says 2 grams, and so there's no consensus in terms of the amounts. And the use does not negate the need for conventional medication. CMOS. Who has heard about CMOS? The ladies in the room definitely know. The younger ladies. The older ones are a bit conservative. Yes? CMOS. And I hear it is cleaned for like 30 minutes. You have to clean it so many times. What is CMOS, by the way? It's an algae. Where do you find algae? In the sea. It's a CMOS. So what does it come with? I shudder swimming in the sea because of the sand and how much of it will stick in my hair. So I'm just wondering what you do with the CMOS when you get it. So it has, it's a red algae found in the sea. Again, antihypertensive, anticoagulant, UV protection, immune modulator, all the good things. just like it promises heaven. But we have very, very, very limited research on the same. Now, there is a study that said if we used 4 grams per day of dehydrated Irish seaweed, like the sea moss, then it would be able to improve the iodine. So if we have iodine deficiency, yes, we could use it, but just 4 grams per day. Now, if you get it from the sea, how do you determine what 4 grams are? If probably they package it, you're able to use it. But what if your problem is not iodine deficiency, and you're using it because now it is being used as anti-aging factor and all that stuff, right? So it is necessary that you check the packaging for the people who pack it, so that you know how much you're consuming and if it is regulated and allowed for use in the kind of situation that you're in. So challenges, it is only beneficial if you have iodine deficiency. If you don't have, please stay away from it, because it actually may interfere with what? Your thyroid treatment for patients who have thyroid disorders. Sea moss can also accumulate a lot of heavy metals. So we are now scared of eating fish because the fish may accumulate heavy metals, and then now you go and add, you stop eating the fish, then you go and add the sea moss, and you end up with the heavier metals with probably no nutrient benefit, as opposed to what you'd have gotten from the fish. And the other one, I think this is like the second last one, gluten-free diet. How many of us are now not taking gluten? You are scared. There are people who are now saying, I'm on a gluten-free diet because, you know, gluten is causing me all these problems. Whereas we agree that as we age, our digestive systems and our bodies are not able to tolerate much of what we tolerated as young people. It is not entirely beneficial that we will say we will not use gluten. Why? Gluten basically is a protein that comes from the plant origins, but usually wheat, barley, and rye, and sometimes a combination of rye and barley, which gives us the triticale. So some people have claimed that if we use a gluten-free diet, then we'll be able to prevent or reverse diabetes. We are yet to see if that is true or not. That it contributes to weight loss. If you've stopped eating gluten and now you're on a gluten-free diet, you may be able to lose some weight. But that's because how we prepare gluten. What does gluten make? It makes chapati, it makes naan, it makes mandazi and donut and all that. So we are looking at gluten, but we are forgetting what else have we added to it that contributes to the extra calories. And now because of the sweetness, you're overeating it, and then you're getting the weight. So if you stop, you have stopped all the other things. It is not necessarily gluten that brought about the weight loss, but all the other extra calories that came with how the gluten was prepared. And reduction in inflammation. This may have some truth in it. Why? Because over the decades, we have had a lot of processing of gluten products. We have overprocessed them, and so that may lead to inflammation. So if we probably stayed a little bit away from it, we might be able to help with that. Now, is it possible to prevent diabetes with a gluten-free diet? This study was not conclusive on that. And whereas it said it has a way that it can be able to reduce the pro-inflammatory cytokines and adipokines, that did not necessarily mean it would be able to do what? To prevent diabetes. Of course, there was the issue of reduction of obesity and lipid control by upregulating the peroxisome proliferator activator receptor alpha, but it is not, we have not said this is it, and this is what it will do. And of course, insulin sensitivity, yes and no, to a very small extent, unless you are actually intolerant to the gluten itself. And of course, there was also claims of, in that study, it increased beta cell volume, and so better insulin sensitivity, but again, not here, not there. So what are the challenges? Unless you actually have a particular disease that makes you stay away from gluten, then it is not necessarily it does not give you any benefit. So for people who have IBS, celiac, and people with gluten intolerance, that may be something positive that you may want to look at, but it does not, if you don't have any of those conditions, whether you eat it or not, might not really give you any effect that we can write home about. Now, when we overly restrict our diets, we might actually end up causing nutrient deficiency. And this, we were looking at it in terms of, let's look at a community where people don't eat ugali, they don't eat matoke, they don't eat the potatoes, and therefore their source of carbohydrates and the grains is basically from the wheat and gluten based. And then you go ahead and restrict this. So where will they get all the other nutrients that they would require? So we might actually end up giving another problem as opposed to what was there in the first place. So in summary, what are we saying? Yes, these things are there, and there are so many other things. Somebody even asked, should we take should we have a low carb, or should we have a keto diet, or should we have a no carbohydrate diet whatsoever? So there are all those questions that come about every time we talk about nutrition, every time I talk about alternative therapies, every time we talk about this should be done and probably this we need to watch out. But our cells will require all the nutrients. There is no, in the case of cancer and diabetes, for example, and we had that in the morning, the patient has got high sugars, the patient has got cancer. So we are busy telling them if they take this particular carbohydrates, their sugars will increase. Now, if their sugars increase because they have cancer, we're also busy telling them that they're going to feed the cancer cells. But we do not have compartmentalized body such that the cancer cells are on one side and the diabetes cells and our growth cells are on another compartment, that we can decide we are feeding section B and leaving A and C. All right? So when we do that, the patients end up with what? Abnormal functioning of the system, and that may cause disease conditions or even make them worse. Now, there is no single nutrient that on its own will act to prevent or to stop a disease or to cure a disease. We cannot say, I am taking CMOS because I have been told I have iron deficiency, and only CMOS, because of that iodine component of it, will heal me of a particular disease. You must use it in a combination with all the other things, if you must. And then if we restrict our diet, as I've said earlier, we might actually end up with what? Nutrient deficiency. And if we really have to do some of these things, then we have to make sure that we work with a professional so that we know what we are doing and we are able to make sure everybody is doing the right thing. So I want to open this session for questions and interactions because I know that will come up. Thank you.
Thank you very much, Betty, for that excellent presentation. And I think at this point, I'd like to just thank the KDSG committee members. I think this time around you did an excellent job in terms of introducing topics that are thought-provoking. In the morning, we had a discussion on insulin. Now we're having a discussion on, complementary and alternative therapy. These are now new things that, we are they're introducing new angles to, diabetes management, and also how else we can optimally treat our patients. So thank you very much, Betty, for that. And I think for me, first and foremost, I think from the take-home message is that similar to overall management of a diabetic patient, also when you're selecting the best pharmacological regimen for a patient, there is no one size fits all. It is individualized. Similar when it comes to nutrition and also just selecting the best treatment, whatever nutritional plan. You have to individualize, and remember that, when you're adopting or recommending a particular nutritional plan, your aim is just not to improve the metabolic profile or whatever, reduce the renal or cardiovascular risk of the patient. You also want to, of course, optimize the function of the patient and to make sure that whatever plan you've introduced is a plan that, fulfills the preferences of the patient. So there's no one size fits all. And like Betty has said, when you're in doubt, there are experts who can guide you on how best to prescribe a nutritional regimen for a patient. So at this point, like Betty has said, we can have a Q&A question. I don't know, anyone with a question? Yes, Jackie.
Thank you, Betty, for that. I want to ask about hibiscus. There are patients who claim hibiscus is an antidiuretic. Is there any truth to that?
Thank you, Jackie.
All right. So what happens when somebody takes hibiscus? Again, even when you look through those studies, they're you'll find they're using 10, 12, 15, 20 people max. and it's within a certain community, so what is our ability to replicate it to another community? So the people who use hibiscus the most would be people in the deserts, usually. South Sudanese and those Arab-like countries have a lot of hibiscus and they use it. So what happens when you take hibiscus? Because of that tangy taste and nature, you end up actually taking so much more, all right? So what will happen to your bladder? It will be full, and what happens? You want to empty it. So whether or not it is actually can be considered as a diuretic, not yet established, but because you take so much more, you may want to empty your bladder so many times, and that is thought to do that. Sometimes you have patients who you have told to increase their intake of water, and they are not able to, because most people actually also say it is very difficult to take plain water as it is. And so when they put the hibiscus into it with that tangy taste, they are able to take so much more. So again, look at somebody who probably because of dehydration, their creatinine and urea levels were not very, very good. And then now they are taking the hibiscus. They've not added sugar, of course. And then the numbers look well. What will they say? It is actually that which made them be able to get to that particular condition. Yeah. So
thank you,
not defined.
Thank you, Betty. And then maybe I would ask Jacqueline, your question, is it with regards to its use in a patient who's fluid overloaded, or what was your thought behind, the thought process behind the question you've just asked?
The two patients who have claimed it helps them, yeah, two patients with lymphedema. Yeah, they say when they use the hibiscus, they find because of the diuretic effects, they have less swelling.
Maybe because they're passing urine too much now.
Okay, thank you. But I think also it must be recommended in very cautiously, particularly among patients in overload state. Patients with heart failure, renal failure, when you tell a patient that, you know, there's this hibiscus that has diuretic therapy, because such patients, there's recommendation for fluid restriction. So how much is, you know, enough and optimum? So it's a very dicey place, and of course, most patients would prefer, you know, the alternative therapy to conventional therapy. So they will overuse with attempts to just optimize its effect. So we must trade cautiously. Yes, Rosie.
Okay, I know the topic is alternative, but this is a question for Tracy. The reality on the ground is people are not using this as alternative, but it's more of in addition to.
Complementary.
Yes, complementary. So my question to you is, I am seated here in front of this lady who says, you know, I don't want tablets, but me, I've been told if I take CMOS and I don't know, cinnamon and turmeric, honestly, like my community, that's everything has to have turmeric, and it works, and honestly, that is how I've been raised. So as a doctor, I'm conflicted a bit by the science because we don't have a basis, but the reality is our patients are actually using them. So when they're seated right in front of you, what is your message, take-home message today for all of us who are seated here, to take or not to take, or what do you advise, what amounts? I'm just curious to hear your opinion.
Thank you for that question. So if you refer a patient, if a patient comes to you as a doctor, first step would be, if they ask about any dietary question, you send them first, you refer them to a nutritionist. I can see you smiling. But when a patient comes to me as a nutritionist, it's my obligation to make them understand, if I consume, whatever you're consuming, is it going to be beneficial for you? Will it have drug-nutrient interaction? Will it reduce the drug efficacy? So it's for us to give the patient first the information and to help them understand. If I take too much of the turmeric, sometimes I even end up telling a patient, okay, you've been told to take CMOS, but this is the other side, because nowadays, before a patient comes to me, Dr. Google works first. They Google, so they'll tell me, but Daktari, my sodium, because definitely they will know their sodiums, they'll be able to, they can read, they'll see their lab results. So they'll tell you, it says it's rich in this particular nutrient. For them, they will rush to that, but now it is for us as dietitians who have the knowledge to tell them, yes, but these are also the side effects when you consume too much. So if you refer a patient to us, we are the better place to know. Thank you. We were always available.
So are we free to call you people?
A question here.
If I'm in Garissa, can I call you freely Betty? Can I call you Tracy-Ann?
Yes, you can.
Okay, excellent.
Maybe we need to tell you, like in your community, they have been using it in food. Now, when you're using turmeric in food, you don't overdo it. The problem comes in when you're trying to make something else out of it. Like now you want to, I know how Indians eat. So the overdoing is the problem. And on your question on whether we can be found, COVID had a good side to it, and we realized that a patient actually does not have to travel from Garissa to Nairobi to see me. There's WhatsApp, and actually now there's network coverage. I think Kenya is actually one of the best covered in terms of internet and network coverage. So yeah, we can still do collaborations with the person on the ground and the patient and myself and all the other dietitians, and we can be able to work out something. Yes.
I wanted to find out, what's the benefit of ginger? You know, during COVID, there was a lot of ginger plus garlic plus lemon, this dawa thing. Because patients, the only thing I tell them is don't add the honey. But it is okay. I don't know.
And a lot of them after that came back with a lot of gastritis. Let me let.
So I think ginger and turmeric, they are very high in antioxidants. So I kind of feel like we'd put them in the same category. So, and then there's no much research, like conclusive research on how much is too much. Are we supposed to take it dry? Are we supposed to take it in liquid form? Are we supposed to take it in capsules? So there's a lot of room for research so that we are able to give the right information to our patients. And I think it's also trying to understand where patients are coming from, walk the journey together, and understand where they're asking such questions. Because Dr. has said, based on their religion, their culture, some things are mandatory. So, but it's also for us to understand and walk the journey with our patients. Thank you.
And then in terms of ginger, there's a bit of comfort it offers in terms of the soreness, and that's because it may have an amount of antibacterial properties, again, not established how much. So again, I may not really, if they're taking and they're okay with it, it's soothing them, it's not causing them any problem, that's fine. But I would not tell them, now go and take 3 cups of dawa in a day because you're trying to cure flu. It doesn't work like that. So in terms of antibacterial properties, yes, but if they can just incorporate it in their normal cooking, that would be better than trying to create dawa out of it, and then it's so concentrated and their gut is not able to deal with.
Okay. Thank you very much, Betty and Tracy-Ann, so far for your responses. Maybe we have time for a question or two.
Yeah, yes. Thank you, Betty and Tracy, for such a good presentation. My question now is, the conversation we need to start having is about how much rather than the type, because I think that is where we are having a serious gap, because people already have an idea of the types they're supposed to take. But the conversation about how much is needed, which again, we don't have a good research to back that, has been missing for the bigger population, even for the care providers. So how do we narrow that conversation now to understand that there is an aspect, despite we have a type that we should be giving, but there is aspect of how much should be given. That is the first conversation. Then the second question I'm asking is about the general population. We have unregulated, maybe herbal medicine type that is within the general population, and also looking at the comorbidities a patient might have and the polypharmacy they are experiencing. And they have the people in the community who have, quote unquote, sweet mouth to convince them of the herbal medicine. So how do we come in as care providers just to narrow that gap. That we have alternative medicine, which that group is doing aggressive work in terms of marketing their product without some scientifically backed information. And then, of course, a patient also is in having several comorbidities, which also necessitates polypharmacy. So how do we end up coming in just to try to provide the right information to the patient? Thank you.
Thank you. In the long term, or as a long shot to it, I'm just thinking widely that we could have a multidisciplinary kind of research. Look at something like okra water and turmeric and cinnamon. These are things that our patients are already using. We are not introducing anything new. How about, and we know they are in the market, how about we go through our conventional, like a researcher, we go through our conventional treatment, then we have one arm that we give a certain dosage of a product that they're already using, another arm we don't, and then follow them up and look at their numbers in terms of, do we have a reduction in HbA1c? For example, if somebody incorporated cinnamon or okra water with their treatment, as opposed to the one who did not have. And then now we will have our own data from home saying this is what we have seen and these are the loopholes and the gaps that we need to fill. That would be one. The second thing, again, would be patient education. And I'm usually very passionate about patient education. And that's why we say for the pressure of the numbers, the physician may not be able to take so much time with the patient. But that diabetes educator, that nutritionist, will actually have 40 to 60 minutes. Sometimes they ask you, why do you charge so much? But you're like, you take 5 minutes with the doctor and you pay as much, but my 40, 50 minutes with you will actually probably lead to a much better outcome in the long term. So if we invest so much in our patient education, just so that we remove those myths. If we don't do it, then the social media will do it for us. And it does it, you know, in a flash, and it's very promising. The third thing, even as we do patient education, and that's why probably you'll need somebody who has done diabetes education or patient education to be able to talk to the patient, because they have that, you know, you want to listen. You're not about, let's just write and there are people I need to deal with. So you are able to package the information. And let's all agree, in medical school, we are not really taught, this is how you'll go and talk to the patient. You are taught about the disease and what to do about it, how to pick it out from the description you're being given. So when it comes to communicating that, you may have very good information, but how you relate it to the patient so that they understand may not be there. So again, just being able to teach ourselves how to interpret the information that we have onto the patients. And of course, lastly, let's not tire about giving the same information every now and then. It might look silly, but understand where the patient is coming from. When a patient tells me they are taking okra and on that day their sugars were low, I'd want to find out how often they take it, and from their diary, the food diary and the medications they're taking, and the blood sugar readings that they're giving me, is it correlating? Yeah, so we don't rubbish them off, we just try and see where they're coming from.
Thank you very much, Betty, for that response, and I concur with you. You must be paid for what you're demanding, because we all agree that patient education actually it's cornerstone in management of chronic disease. No matter what medication, you know, the one that has, you know, been shown to have the latest evidence, if your patient is not well empowered to understand the disease, to understand why they need to take the medication, you're not going to have the to achieve the outcomes you do deserve. So I agree with you, patient education is key in management of any chronic disease. So I think one question and then one from that end, and then maybe we can just wrap this up.
Hi Betty, hi Tracy-Ann, really brilliant presentation. Now my question is not particularly on alternative therapies, but just for us to be on the same page as far as type 2 diabetes is concerned in relation to the direct study. What are your thoughts as far as implementing the low-carb diet is concerned, especially for the class of patients that we get? I work in an ASAL county that borders Mount Kenya, and we all know Mount Kenya has really good prevalence. Forget about the word good at this point, but the numbers are still increasing, and CKD tagging along that. So what are your thoughts as far as prevention of comorbidities are concerned by use of the interpretation of the direct study and implementation of the low-carb diet. Thank you.
We all agree that the direct study was really, it was necessary, and we saw very good outcomes from it. We've tried to implement the low-carb diets in our local settings, and we're seeing very beautiful results. The biggest issue is, as a group seated here, are we able to determine what is low carb, what is very low carb, and what is keto versus what is high carb? So anything between 75 grams to about 150 grams of carbohydrate in a day is considered low carbohydrate diet. Now, what is the sustainability of the same? Where is the patient coming from? You just said you're in ASAL areas, the carbs will be probably slightly less than the Mount Kenya counterparts, where the carbs will be very, very large. Okay, so again, do you have a stepwise approach to it? Now, look at the direct study. This was a controlled environment. This is the match we're giving you for this period, then we graduate to this and that. We might not be able to replicate the same in the same manner in our setting, but you can always start where the patient is and make sure that we get our numbers to where they require to be. So probably a patient is coming to you, and what I see most commonly, uncontrolled blood sugars, very high HbA1cs, they are almost getting into complications or just about to get into complications, and you ask for a 24-hour recall, and you write that down, the dietary frequency, and somebody is eating as much as 1,000 grams of carbohydrates in a day, of course unknowingly. Now, I know I want to take you to 75 to 150. What is the practicability and the feasibility of getting you from 1,000 to 150 without you giving up? It might be, I'll get you from 1,000, get you to 800, get you to 600, like that, until we are able to do even the 75. What is the challenge? I will see the patient the first time. They'll go back to the doctor. Their sugars are still not good but behaving. They'll be sent back for my appointment. The third time that their sugars behave even for 1 week, I will not see them until another 3 years when they have CKD, and now they have been sent by their primary physician from diabetes side. They have been sent by the nephro. They're like, you need to go and find a dietitian. To do what? Because we don't perform miracles. So again, if we put it in such a way that you have sent me the patient, when they come back to you, you want to find out what it is that they learned, where they are, what they're struggling with, and ask them to come back. We see them again, send you back to your doctor, what have we managed, and move on to the next. Then we'd have a stepwise approach and not waiting for miracles. But yes, it does work. We just have to be careful about it. And also, not to tell our patients to go on a no carb. You still need energy. Otherwise, then we have these people who are not eating carbohydrates at all, and they're fighting everybody in the office because their cortisol levels are just up high there. KRA is asking for money. Their relatives are doing what? So they are angry and hungry, and then they're just fighting everybody. So there must be some carbs. Yes.
Thank you very much, Betty, for that response. I think I would request one more question from this end. It's very quiet. Any question? Thank you, Dr.
Yes, the thyroid cases, they usually ask me what diet they should take. So please advise me today. Thank you.
Thank you, Dr. for that question.
Dr. Simba, I have a response. You send me that patient first. And then 2, depending on, sometimes we have thyroid disorders which shifts from hypo, sometimes it's hyper, and all that in between. So if we say that we are going to tell you, now go and tell them not to eat cruciferous vegetables, for example, because it will interfere with the iodine and all that stuff, I'll be lying because I do not know at what point they'll shift from being hypo to hyper. That's 1. 2, I have this patient probably who has hyperthyroidism, and their issue is they have this excess weight loss and all that stuff, and they are worried about it, and they're very aggressive. Sometimes they want to eat, other times they don't want to eat. Then the hypothyroidism on the other side, there's obesity, there's a bit of water retention, and then they've Googled, so they're telling me that weight is because of water retention. Water retention is like 2%, and then your BMI is at 40, so we have to find out what else you have been doing so that we can start moving this BMI down. And one of the few things that I do is a complete body composition analysis, so that you're not just stepping on on the scale and your weight is 100, and then you convince me that everybody in your family weighs 150, you are the smallest. That's okay, but the machine is reading something else. Maybe your fat percentage is high, maybe your water, you know, there's a bit of retention or something. Some people even say their bones are heavy. And then they stand on that machine and their bones are 2.5 kilograms. And the weight is on the other side. So again, just do a comprehensive body composition analysis, and then we work with the patient. If it is a patient that has hypothyroidism, for example, and we are careful about the cruciferous vegetables, again is to ask, which side of this country do they come from? Because the side that I come from, we normally don't even take cruciferous vegetables. We are taking managus and all that stuff. So I would be ill-informed to tell them not to take cruciferous when they don't take in the first place. Now, the other people from the mountain, we know they can eat cabbage for breakfast, lunch, and dinner, January to December, and they are okay with it. So again, you'd have to watch on that. Or the people who are on... again, what is cruciferous vegetables? Yeah, you might be talking to someone to stop eating cauliflowers and the broccolis and you know, the spinach for what it is, not the collard green, which we call spinach, and they don't even eat some of those things. Or you're telling them, don't go eat Brussels sprouts. How many of you in this room eat Brussels sprouts? You don't know. So again, it is very individualized, and again, depending on the treatment and the amounts that they're taking.
Thank you very much,
Dr. Odhiambo's hand went up so hard.
Last question. This one has to be the last question because our time is up.
Thank you very much for the presenters. Almost every day I get asked by my cancer patients, what should I eat, what shouldn't I eat? A lot of times they are convicted that what they eat predisposes them to getting their cancer, and most of them are struggling already with malnutrition, but they are really starving themselves nearly to death at home. I'd like to hear a take from each of you. Thank you.
Okay, I'll give it to Tracy because she does more onco than I do. Is it 3 weeks ago that we had this patient who weighed 34 kilograms, could not start, 36 kilograms, 60-year-old, could not start treatment because really, what do you do with such an underweight patient and all that? And they had been stopped from eating everything. For breakfast, they would have half Weetabix with no milk because milk causes cancer. For, I think, 10 o'clock, they would have black tea with a piece of ndoma. It was just terrible. And anyway, we were able to even supplement. Now, the biggest issue was she was not even ready to take the supplements because she's been told those are the things that will send her to her grave very fast. So we are talking about low volume. After you've not eaten for so long, there's no way you can just start eating, however much I know what you want to eat. So again, we need low volume, high calorie, high proteins and all that to be able to supplement the patient. And I think they've already added more than 10 kilograms after that. They're starting treatment. So the misinformation that is out there is really, really big. And that's something we need to correct. And maybe we're not in when we said we cannot compartmentalize the body and say we are feeding the cancer cells, so we are trying to starve them. As you're starving the cancer cells, we are also starving the human person, and it goes hand in hand. But I think she does more onco than me. She might be able to have a better input.
Dr. Send the patient. And yes, the question is, for me, when a patient, especially in oncology patients, I tell them to eat everything and anything. Depending, what's our goal of care? A patient is in stage 4, do not take this, don't take this, don't take this, and the patient is on palliative. What are we doing to the patient? So my first questions, my 3 questions are, type of disease, where's the disease, so that I know what are we supposed to feed the patient. 2, our cancer patients really go it depends where, especially if the cancer is head and neck, we are definitely going to see cachexia, malnutrition. So our patients need high energy, high protein. So that's another thing. 2, even still at number 2, we need to look at our first criteria. Does the patient afford? Which type of food are we telling? Which type of supplement are we telling the patients to take? Then number 3, it's very easy. When you have to make sure that the patient is meeting their energy requirements and being followed up. Especially what Betty says. I've seen this enough times. I get patients, stage 1, stage 2, they're doing very well, they're chemo, they're radio, they're improving and things are going fine. I see them back when they're at the stages of end of life, refractory, cachexic, there's nothing I can do. they lose a lot of protein. We need a lot of muscles, especially when the patients are going through our therapies. So the question of what do I eat, the answer here is to eat. It's not to eat, it's to eat. But now the answer with the to eat is how much are we eating? What are we eating and how much are we eating? I hope I've answered your question. Thank you.
Okay, thank you very much. And unfortunately, we've come to the end of this session when things are getting more interesting and more thought-provoking questions are being asked. Thank you very much to our presenter, Betty, and also your counterpart and colleague, Presian. Thank you for those well-informed responses. Thank you very much. We've come to the end of the session.
I'm just being told to remind all of us that the next session starts at 6 p.m. So you can walk around and be back by 6 p.m. And we always start on time, so don't be late. Thank you.
So today I will don't laugh at my potatoes.
I wanted to pick on that pregnant stomach, but then I decided, let me spare you for the love of God.